webinar. My name is Maria Bunos, and I'm the practice lead for coding and reimbursement here from Wolters Kluwer. Let me go over a few quick instructions on how to use the webinar system. For questions, please use the question tab or menu bar item located on the GoToWebinar menu on the right side of your screen to submit questions. All lines have been placed on mute, and we will address questions towards the end of today's presentation. For handouts, you can download a copy of today's presentation by selecting the Handouts button on the GoToWebinar tab or menu and follow the instructions to download the handouts. There will also be handouts included in the automated webinar follow-up email that will be sent within about 48 hours of today's event. For CEUs, today's webinar has been approved for 1 CEU from AHIMA and 1.5 hours of CEU from AAPC. An email with a survey and download instructions will be sent again within 48 hours of today's webinar. And with that out of the way, it is my pleasure to introduce to you our speaker today, Barry Libman. Barry is the president and founder of Barry Libman, Inc. and Libman Education. Prior to forming Barry Libman, Inc. in 1998 and Libman Education in 2012, Barry held a number of positions in the health information management field, working for hospitals, insurers, consulting firms, and regulatory bodies. He is recognized for his in-depth knowledge of coding and reimbursement issues for acute care hospitals, with particular interest and expertise in long-term care. Barry is often called upon to provide education and training on code updates and coding issues. He is a AHIMA-approved ICD-10 trainer, a graduate of Northeastern University, and holds a master's in healthcare administration from Simmons College. And without further ado, it is my pleasure to introduce to you Barry Libman. Barry?
Thank you, Maria. Lots to talk about today. Our emphasis is one of the most recent coding clinics that came to us in recent months. But first and foremost, I want to talk a little bit about some coding news just to get us started. You may be aware that on March 9th and 10th, the Coordination and Maintenance Committee met on March, and during that time, they gave us information on the new PCS codes that are being released for fiscal year 2017 and the new diagnosis codes, the CM codes. As you can see, 3,651 new PCS codes. While we have 487 revised code titles, in essence, those are actually new procedure codes by virtue of their new title, and the same for the diagnosis codes. I'd like to point out that the sessions on the 9th and 10th are recorded and on YouTube, and I believe that they are worthwhile listening. They summarize the current issues in our classification, and you can also receive continuing education credits. On the PCS side, the discussion entailed for the new PCS codes for 2017, most of the codes are new cardiovascular codes, representing a change in how we count the number of lesions that are treated, as well as the ability to report different kinds of stents. On the diagnosis side, many new codes, mostly, I recommend looking at the tables to get a sense of what's going on. We do not yet have new guidelines for 2017. They've not yet been released, but we anxiously await because that will give us some guidance as to how to utilize the new codes that are being given to us. And while I believe you should watch the YouTube videos for their educational value, I think you should take advantage, if possible, of the continuing education unit opportunity that it does provide. I've just provided this slide because this is the language from the handout from the Coordination and Maintenance Committee meeting, which I think if you're going to watch the YouTube videos, you should download because they provide excellent guidance to the material you'll be watching on YouTube, and you can get about 9 hours worth of CEUs there. Some new codes that we will definitely be getting this year are those pertaining to the Zika virus. We've already been told A92.5 will replace A92.8 for how we classify the Zika virus. A lot of information out there. I recommend visiting the Center for Disease Control website, as well as there are 2 specific articles relating to a summary of the Zika virus and its progression. Depending on what your preference is, you can use JAMA, you can use New England Journal of Medicine, but I think as we prepare for the potential to have to report this diagnosis, getting a good clinical background would be worthwhile, and these are excellent sources with which to do so. Next, we have the inpatient prospective payment proposed rule for fiscal year 2017, which was published April 27th. It's always a dilemma to decide whether or not to read the proposed rule or whether or not to wait for the final rule, but because so much is changing in ICD-10, if this was the year you thought you wanted to read the proposed rule, this would be an excellent time to start with this rule to get a sense of where the changes are going to take place. One of the things that we noticed in the past year was that many procedure codes that we were quite familiar with where they lined up in the DRG payment methodology are actually being realigned by means of the new proposed rule. Some of them are corrections, just to get a sense of where that's all going to happen. That's outlined as one of the parts of the proposed rule. And before we jump into any coding clinic presentation, I always want to talk about the new method for asking questions of coding clinic. It's a relatively new process and involves tracking online. It used to be, as you recall, in the old days, you would write a letter, you would fax, and you'd never really know what became of your request. And this online submission of questions to Coding Clinic is a huge improvement over the old process. You register, you submit your request, you get a tracking number, and you get to follow your progress of your question. And I highly recommend using it. It's there, so just kind of an advertisement for that. Quickly, a talk about where we stand with coding clinics. And the reason I always talk about this and show this slide is that while we talk about ICD-10 coding clinics, it's important to realize that there is ICD-10 guidance given to us in some of the older ICD-9 coding clinics, and that there are 5 there before we jumped in on first quarter 2014 for ICD-10. And our current situation now is the most recent coding clinic we're going to discuss today is the material from March 18th, but the next quarter, second quarter, which we're in right now, is due out any day now. And you can see from the dates listed on this slide that generally Coding Clinic has progressed to a process where they're submitting the information to us about midway through the quarter. Last quarter they gave us March 18th, and right now we're waiting. Today's the 17th. I would bet that the next Coding Clinic comes out in the next few days if they stay on the schedule that they've been on. Coding Clinic transition. In 2013, the discussion was generally along the lines of this Coding Clinic, which told us that there were no plans to translate all previous issues of Coding Clinic of 9 into 10, since many of the questions were very specific to 9. Many people focused on the word all, wondering whether some would be translated or not, whether there would be no new coding clinics and all new advice would start with Coding Clinic for ICD-10. However, fourth quarter 2015 tells us that a lot of information was not unique to 9, and therefore those coding clinics would remain applicable for ICD-10 with some caveats. As long as there was nothing new published in Coding Clinic for ICD-10 and PCS to replace a previous coding clinic, the previous advice would stand. And that's mostly not code-specific, but clinical situation-specific circumstances. So that's actually kind of reassuring. So while they tell us that much of the information will not be republished, the remainder of that Coding Clinic actually tells us that certain information that they deem very important to remind us of will in fact continue to be republished. Next, we're going to talk about the hierarchy of guidance. Where does Coding Clinic stand in the hierarchy? First and foremost, we have the conventions of the classification that must always be followed. Second, we have the official coding guidelines, which are subsequent to that. And Coding Clinic is really third in that hierarchy. And the reason we know that is that the Coding Clinic guidelines actually tell us that. And you see the highlighted phrase here, the instructions and conventions of the classification take precedence over the guidelines. A very important foundation. Adherence to these guidelines when assigning ICD-10-CM diagnosis codes is required under HIPAA, which means if you choose not to follow the guidelines, among the other things that you are not doing correctly, you're violating HIPAA, just to point that out. Next, Coding Clinic themes. When you open a Coding Clinic, these are the general items, the questions you would ask yourself as you review the questions. And what Coding Clinic now gives us are a range of themes, guidance that is the same as ICD-9 as it is in ICD-10. And that's a very assuring thing to know, that we approach certain circumstances the very same way we did in 10 as we did in 9. And then, of course, there's guidance that is drastically different from 9 into 10. And we're going to talk a little bit about some examples of that today. There are corrections to the classification. Building a classification is a huge undertaking, and sometimes mistakes are made. Coding clinics have highlighted some of these rather dramatic mistakes and told us how to correct them until the code freezes over, which will be this fall. Empowering coding clinics. In coding clinics that tell us how to look at clinical circumstances, and rather than wait for a query or wait for a future coding clinic to answer the question, we are now able to make decisions on this information ourselves. And probably one of the best new features in Coding Clinic that really they did not utilize back in the days of ICD-9 was addressing complex issues with multiple examples. And if you've been keeping up on Coding Clinic, you'll notice that there have been issues that summarize long-term care coding with a multitude of examples. Coding Clinic that summarizes how to code the variety of situations of mechanical ventilation, for debridement, for treatment, for use of seventh characters with injuries, drainage of hematoma, cerebral hematomas, traumatic and otherwise. And today we're going to talk about addressing some obstetric coding issues. This is a list of today's topics that we hope to get to. So let's jump right in. First, I want to talk about excludes notes. And before we discuss excludes notes, I want to get a look at the guidelines in preparation. And these are the guidelines for how we handle excludes notes in ICD-10. There are two types. They have different definitions, but they indicate that codes excluded from each other are independent of each other. And I've given you the reference so you can go look that up at the bottom of the page. I personally have always found the notion of exclusion notes particularly confusing in ICD-10 now that they've broken them down into excludes 1 and excludes 2 notes. Excludes 1 notes are really what we always did with exclusion notes in ICD-9, where you had a code, but there was information at the code you went to, and your clinical information led you through the exclusion note to understand you shouldn't stay here, you should go get a code elsewhere, which means an excludes 1 note would be use this code. No, it doesn't. The excludes 1 note means you've gotten to this point, but go find another code. Another code would be the correct code based on all of the information. An excludes 2 note means it's not included here, which means that you would use both this code in the excludes note and another code that you would go to amplify that code and make the circumstance coded more specific. And the reason we talk about this is that on the National Center for Health Statistics website recently, there was a statement that told us, and you see in the first paragraph, that they are offering some interim advice as it pertains to excludes 1 notes and unrelated conditions. And the real information here comes in the second paragraph. There are circumstances that have been identified where some conditions in excludes 1 notes should be allowed to be coded, and thus might be appropriate for excludes 2 notes, which basically means that the complexity of the exclusion notes confused not only me, but the folks who developed the classification, and they're going to fix this October 1st. But this note from the National Center for Health Statistics reminds us that all bets are off at the moment, that you now have the freedom to do the right thing when you see the exclusion note, the excludes 1 note, and move on. This is an example of just one of many. I have not actually found too many, but this is a rather obvious one. At the 3-character category J44 for chronic obstructive pulmonary disease, as you see, most of the conditions there are related, making them excludes 1 notes, meaning that if you had the specificity of COPD that was bronchiectasis, you would go to J47. As you work down the list, you see. But when you get to the last line, you see lung diseases due to external agents, J60 through J70. And what you realize is, under the example of aspiration pneumonia, is that aspiration pneumonia is really unrelated to chronic obstructive pulmonary disease, and therefore this would be one of those circumstances where you could code chronic obstructive pulmonary disease, but also code J69.0, the aspiration pneumonia as well, despite the fact that the excludes one note tells you that you shouldn't be staying at J44, you should be moving on to J69 completely. Just wanted to offer one example, and these are the sorts of things that this coding clinic advice allows you to do. So in case you're not a regular reader of coding of the National Center for Health Statistics website, there's a coding clinic here that pretty much says what I've just said, but wanted to show you the fourth quarter 2015 coding clinic that says we've received several questions regarding the interpretation of excludes one notes, and the answer to that is if the two conditions are not related, it is certainly permissible to report both codes despite the fact it's the presence of an excludes one note. This is a very important coding clinic that's going to free up a lot of confusion until all of the excludes one notes get corrected this October. Okay. Next, a coding clinic guideline that we always start with because it speaks to the foundations of medical record documentation. Here we have, is there a guideline or rule that indicates that you should only use the medical record documentation for that specific purpose for coding that visit? It goes on to say, does each visit or admission stand alone? And would the coder go back to previous encounters to assist in the coding of a current visit or admission? And even now I can hear you out there shouting the answers because I know you know them. The answers are in that order, yes, yes, and no. But let's look at the reasons why. Here we have a couple of slides that summarize the answers. The first statement sets up the principle. Documentation for the current encounter should clearly reflect those diagnoses that are current and relevant for that encounter. There you have that. Conditions documented on previous encounters may not be clinically relevant, and the patient's historical problem list is not necessarily the same for each encounter or visit. Those two sentences really, and paragraphs, really address the problem we now experience with the electronic record and the problem of cutting and pasting, where information from previous visits is sometimes brought forward without being edited. Just there you have that. And it's the physician's responsibility to determine the diagnoses that are applicable, reminding us of the source of the documentation. And however, and this is the real answer to the question, however, if the condition is not documented in the current health record, it would not be appropriate to go back to previous encounters to retrieve the diagnosis without physician confirmation. And this is really an opportunity where if you have information from a previous encounter or admission to query to see if it would be appropriate under the right circumstances with an appropriately written query to bring that information forward. The next paragraph talks about clinician education. And lastly, to be aware that this advice applies to both ICD-9 and ICD-10, which really drives home the point that we want to have consistent documentation collection practices flowing smoothly from ICD-9 into ICD-10. Next, I want to start and talk about a confusing present on admission guideline, and this is the guideline regarding combination codes. And the guideline says assign N as your POA character if any part of the combination code was not present on admission. And I found that very helpful to be reminded of that because I know coders are sometimes, well, let's look at some examples at the bottom of the page. Chronic obstructive lung disease with acute exacerbation, and the exacerbation was not present on admission. You would assign a present on admission indicator of no, meaning the COPD was present on admission, but because the exacerbation occurred sometime during the visit, not all of the condition was present on admission, thereby we assign no for our present on admission indicator. A known gastric ulcer that starts bleeding after the patient is admitted would also have a present on admission indicator of no, and asthma, status asthmaticus, congestive heart failure that decompensates would be present on admission of no. So you start to get a sense of how this actually works. And of course, the reason we talk about it in the context of Coding Clinic is Coding Clinic in the first quarter 2009 gave us a clarification regarding the progression of a stage 2 pressure ulcer into a stage 3 pressure ulcer. And the question, as you see here, refers back to a previous Coding Clinic in 2008, which states that a stage 2 pressure ulcer that was present on admission and progresses to a stage 3 during the stay is reported as a POA indicator of yes for present on admission. And the question is, are you sure? Because the guideline, as we understand it from the previous slide, tells us that if any portion of the code was not present on admission, we would call it a no. And in fact, they're requesting a clarification on the basis that this seems to conflict with the actual guideline. And here's the answer. In terms of coding POA and reporting, a pressure ulcer is only coded and reported once at the highest stage of the pressure ulcer. Information published in Coding Clinic and the previous Coding Clinic is in fact correct, and we're revisiting it at this moment, and our clarification is to clarify that the previous Coding Clinic is correct. So basically, the pressure ulcer code is a combination of both the ulcer and the stage, but the issue here is the focusing on the ulcer's presence, not the ulcer's stage, and the reason is explained further in this Coding Clinic. It's a National Quality Forum measure, and they've had their hand in the development of this Coding Clinic. And the issue really becomes that patients who have Coding Clinics come into a facility, the Coding Clinic is underway. Given perhaps their other physical issues, the Coding Clinic is not being given a chance to heal, and therefore we're going to call this a POA of yes. It's just to keep there. And just wanted to show you the previous Coding Clinic from 2008, and you can see here admitted with stage 2 progresses to stage 3, and the answer is use a POA indicator of yes. And the reason I show you this is that coders want to know the source of everything, and we're here to show you that. Generally, we as an industry are of the belief you trust no one, you need to know your source documents, you need to find your source documents, and there you have it. Moving on, a related topic is that of debridement. Can you clarify what determines that a debridement in ICD-10-PCS is excisional? We have a quote from a procedure note. I have debrided the abscess cavity, removing necrotic tissue and bone by sharp debridement. Does the word excision need to be present as it did with ICD-9? And the answer, of course, is yes. The documentation for coding excisional debridement in 10 is the same as it is in ICD-9. As in 9, the word sharp debridement is not sufficient. A code is assigned for excisional debridement when the provider documents excisional debridement, and that's all there is to it. Excisional debridement is an excisional debridement, and nothing short of that cuts the mustard on this one. So I want to make you aware of that and to revisit that. The next item I want to visit is deep tissue injury, and this is really coming to us from an improvement in the ICD-10 index. In ICD-10, we have the phrase DTI, or deep tissue injury, and it is a synonym for pressure ulcer. This construct did not exist in the index in ICD-9, and when you go to the index, you know this because you look under injury, you look under your subterm, you go to the main term injury, you go to your subterm deep tissue, and your further subterm meaning pressure ulcer. And this is very interesting because it's one of the few places in the ICD-10 index where the word meaning, where there's actually some interpretation that can occur. We're not clairvoyant. We don't tend to know whether someone means a deep tissue injury is in fact a pressure ulcer, but generally that is what that phrase is intended to mean. And it's worth just kind of mentioning that the word meaning doesn't appear in the ICD-10 index all that often. And I know, having said that, you're going to go to your electronic version of the book and you're going to do Control F and search the word meaning to see how many times that appears. And it appears probably a dozen times. Azotemia, meaning uremia. Okay, that's one of the sepsis, meaning septicemia. So you start to get a sense of where the interpretation has to occur. But I wanted to bring this to your attention that now they're telling us that a deep tissue injury is a synonym for a pressure ulcer, to bring that to your attention. One other I wanted to point out is the notion of post-op complication. Here, if you are given the literal phrase post-operative something, whatever the condition is, you're now, when you go to the index, you can look up the term, the main term, post-operative. It tells you to see complication. And this is an inflexible instruction. It doesn't say see also, where you might use information from here as well as where you go to see also. It means that for a post-operative condition identified as such, you are sent to the term, to the main term, complication post-operative, equating the phrase post-operative, the relationship in time of a circumstance, to an actual post-operative complication. And we're going to look at a coding clinic later today that actually summarizes that. But I did want to bring this to your attention because this is actually a new entry in the index as well for ICD-10. This whole notion is complicated a little bit by the guideline, but remember, the conventions of the classification take precedence over the guidelines per the actual guidelines telling us that. And this guideline is guideline 16. Code assignment is based on the provider's documentation of the relationship of the condition, of the care, or the procedure. And there must be a cause and effect relationship between the care provided and the condition. And an indication that that's not supposed to happen. An indication that we need a specific statement of the relationship of the condition and that it is a complication. So I just wanted to bring that to your attention, and we're going to revisit that. But one of the reasons I talk about some changes to the index is the next coding clinic I want to talk about, which is a very significant coding clinic. We're going to spend a little bit of time here. The index tells us, and this is about how to code hemorrhage due to extrinsic circulating anticoagulants. We have extrinsic circulating anticoagulants, which are the medication, patients who are on anticoagulants, and we have intrinsic. We have the extrinsic from the circulating, we have the intrinsic, which is the innate coagulopathy, perhaps genetic, etc. The reason I point this out here is that you would look under the term disorder, hemorrhage drug-induced due to extrinsic, and you're led to code D6832. I did want to point out that you can't find this if you look under hemorrhage, and you can't find this if you look under bleeding. You can only find this D6832, and I expect that the index will be improved over time. And this is one of the reasons why many people, including myself, were not aware of this until this coding clinic came out, and really as an advertisement for this new code and how to use it. And let's have a look at how that occurs. Here's the first question in coding clinic. What is the code assignment for a duodenal ulcer with hemorrhage due to Coumadin therapy? Is D6832 hemorrhagic disorder due to extrinsic circulating anticoagulant assigned for bleeding that is due to anticoagulant therapy? As you might expect, these are the codes that you would use to describe that clinical circumstance. You have your K26 code for your ulcer. You have your D6832, hemorrhagic disorder due to extrinsic circulating anticoagulant, and T45.515, and I believe, because this is an initial episode, you would use the seventh character of A. I'm not sure why it's not on my slide. Of course, having looked at this many times, this is the first time I've noted this. Depending on the circumstances of the admission, it may be appropriate to sequence either K26.4 or the D6832 first. It really depends on what's being treated and how this is, if a procedure were being done to stop the bleeding, you would use K26.4. But if this were a process where they were going to reverse or get the anticoagulant, the bleeding times under control, perhaps D6832 would be the principal diagnosis. But this coding clinic tells us that regardless, you are required to use an adverse effect code. And people fuss about this a little bit because sometimes they think that this isn't an adverse effect, it's an expected effect. Well, even if you think it's expected, coding clinic wants this to be reported as an adverse effect using the T45, and that's pretty much all there is to it. Next question. Should bleeding due to the therapeutic anticoagulant be coded as a hemorrhagic disorder, meaning category D68? Rather lengthy answer. For the most part, hemorrhagic disorder or coagulation defects must be specifically diagnosed and documented by the provider. And frankly, this isn't usually a problem. This is pretty clearly stated that the bleeding is caused by either the adverse effect of the anticoagulant. However, for bleeding, the specific bleeding type, hemoptysis, hematuria, etc., that is associated, you would also code that, but you would assign D6832, the hemorrhagic disorder, to represent the cause of that specific type of bleeding. This is supported by the inclusion note at D6832, and we're going to talk about that inclusion note in a second, which says drug-induced hemorrhagic disorder. And again, the sequencing of the codes, which is principal and which is not, really depends on the circumstances. But let's have a look at that inclusion term. And the reason I bring it up is that when this coding clinic was published, someone called and said they thought there was a mistake in this coding clinic because they said the coding clinic says we must follow the inclusion term. Actually, what they said to me was the coding clinic says that we must follow the inclusion note. And so I went and I looked at it very carefully, and this is in fact a snapshot of the tabular portion of the book. And in fact, there is no inclusion note here, but there are 4 inclusion terms: drug-induced hemorrhagic disorder, disorder due to increase in anti-2A, anti-XA, and hyperheparinemia. Anti-2A and XA are different types of action by different anticoagulants, and here we have the instructional term use also. So there is no an inclusion note which would say, let's look at the definitions is really my point. An inclusion note appears immediately under a 3-character code to give further examples, whereas inclusion terms are list of some of the diagnoses that are assigned to that code. Because remember, it's a classification, and multiple sorts of diagnoses can be assigned to a certain code. So here under guideline 11, it's worth noting, and I just want to go back, these are your inclusion terms, the 4 codes. And here, the definition of them is that these are a list of terms included under some codes. They may be synonyms, but the list of terms are not necessarily exhaustive. And that means that while we look at it, there may be other phrases that can be assigned to D6832. And for new coders, we always point this out, that the list is not completely inclusive, meaning these are some of the examples, because new coders often look at inclusion terms and say, the phrase I have is not there, the index led me here, but the inclusion term doesn't say what I need it to say. The fact that the index led you there is sufficient, and the inclusion terms are merely some examples of what might be the case. Next, a very important coding clinic, and this is the one that relates to our postoperative complication discussion that we had earlier. This patient underwent an emergency ileocystectomy. The patient's stay was complicated by a postoperative coagulopathy and hemorrhage due to Prasugrel and aspirin. And what they're really telling us here, it was emergent surgery, there was no time to reverse the anticoagulant status of the patient, and therefore bleeding occurred postoperatively. And as a result, the question given to us is, what is the appropriate code for the acquired coagulopathy secondary to these 2 medications? And the answer is, and here is the list of codes, the hemorrhagic disorder, D6832, the adverse effect code of the Prasugrel, the adverse effect code for the aspirin. But the real point of this coding clinic is where they tell us you would also use K91.840 to report the post-procedural hemorrhage and hematoma of a digestive system organ or structure following a digestive system procedure. Coding clinic goes on with a lengthy description of how Prasugrel works, which we're not going to get into. But the real point here is that although, and I just want to go back for a second, we have the language on the 3rd line here, postoperative coagulopathy. You remember what we saw in our discussion of that new index entry earlier on, and that new index entry is now requiring us to report a post-procedural hemorrhage using this complication of the procedure code. So just to keep that in mind, that's one of the points of this specific coding clinic. And at this point in the presentation, I'm going to turn over to Christina, who has a couple of words to say.
Thank you, Barry. Bear with me just one moment, folks, while I switch screens. What I'm going to do is take an opportunity to demonstrate to you in our coding suite some of the content that Barry's covering related to Coding Clinic. So Barry, can you just confirm that you are seeing
I see
the Audit Revenue Resource Center?
I'm seeing your screen, yes.
Okay, perfect. Thanks so much. So while we're focused on Coding Clinic for ICD-10, I want to also cover some of the other ICD-10 resources that are available within both our compliance and our coding suites. If you have any level of our product offerings, you do have access to ICD-10 resources right at your fingertips. And today, I'm in our most comprehensive products, such as the Audit Revenue Resource Center, which I have up on my screen right now. You also have a full gamut of regulatory content, as well as advanced content such as the AHA Coding Clinic, as well as the AHA ICD-10 Handbook. I can directly access my coding clinics from over here, and that would include both the older I-9 versions, the ICD-10 version, which I'm going to go in today, as well as the HCFIX versions, and I can search. These are fully searchable, so I can search for a term such as anticoagulant that Barry was just covering to identify if there's been any current issues in there. You can see that latest November 2016 or first quarter 2016 ICD-10 Coding Clinic citation. And so specifically, I could walk into that citation to see the documentation that was communicated in that coding clinic. In addition, also under Codebooks and Guidance, here on my left, I can walk directly into all of my code sets. All of your current code sets are available, and in our top-tiered products, all the archived code sets. But walking into ICD-10-CM, I can either search or browse. You'll note that we do put the coding guidelines right in the collection, so that therefore when you are searching, you're able to search those guidelines at the same time. You can see that we're breaking it down by the tabular, just like you would have in one of your paper books. And I can walk into a given chapter to see the specific guidelines that have been covered. And even when I land on a specific code page, in here you'll note, I can see the additional chapter guidelines. They're all still going to be visible to me. I don't have to flip backwards. We do spell out all of the reportable codes in bold so that you actually don't have to go back and forth to construct your code to obtain those last digits. So all the codes will be displayed on page. And as such, that does sometimes, because ICD-10 is large, make the pages a little longer, so we gave you the ability to collapse specifically a code range or expand it out further to see the breakdown. So that functionality is available as well. Now likewise with PCS, same idea. You do have access to the current code sets as well as the archive version. The coding guidelines are in the code book, as well as the ICD-10-PCS reference manual. And I can walk again into a given code, a chapter, or a specific guideline to specifically construct my PCS code. And again, you'll notice the reportable codes there down at the bottom, all spelled out right on screen for you, which therefore makes all those codes searchable. So that's always going to be really helpful. Now also in our coding suite, we also have access to an ICD Code Explorer, and I did want to show you that. That particular tool will search both ICD-9 and I-10 at the same time. I can term search, word search, or I can actually enter in a code. I'm just going to go ahead and enter in a term, and this is going to search both I-9 and 10 simultaneously, showing me my code results on screen side by side. At this point, there hasn't been any mapping. We do include the gems within the ICD Explorer. We have all three map gems, and the square symbol here is going to allow me to go ahead and crosswalk and map using the gems to see how that particular code crosswalked either forward, backwards, or with the reimbursement mappings. Always very helpful. Additionally, we recently enhanced the ICD Explorer, and what's really helpful here are the links right next to the coding category. You'll notice here I can go right to my code book from this view. It's going to take me to that page of the code book. It also pre-searches any of my LCDs, and this is based on states that I have already preferenced. So based on my preferred states, I can see where that code has already been mentioned in LCD specifically. And I've got a few states turned on, so I'm seeing results in a number of states. And once I navigate in, I'm going to actually see the full LCD, in this case a draft one, but I'm going to see the LCD that I would normally find on the Medicare database. So those are always really helpful as well. Likewise, on the right next to that LCD link, you'll notice there is a coding guidance link. That is going to link me to our guidance library. And as we're talking about Coding Clinic, you'll notice that this is pre-searched that library. This library has a number of CMS resources that are very valuable, but it also includes those advanced titles. So things like your AHA Coding Clinic, your coding handbook and answer book. So all very helpful resources to make sure I code correctly. Now, as payment goes hand in hand with coding, specifically related to the proposed rule that Barry was mentioning earlier, we do create, when the proposed and final rules come out, we create e-books. And those books allow you to visualize the proposed rule into nice, sizable chapters. In addition, you'll note that the Download Center is going to house things like your tables that are going to reference your diagnosis codes that we were speaking of earlier and procedure codes. So those approved codes. So that's helpful. While I don't have a lot more time today to actually show you the calculators, we do have a MSDRG grouper and calculator that comes with your subscription. And you also have an option to upgrade to our MSDRG analyzer for deeper DRG analysis. Lastly, as we all need to keep our fingers on the pulse of coding changes, regulatory updates, our subscription provides customizable daily alerts. In this alert, we would notify you when we have updated, when the new coding clinic has been released and updated in our collection. We'll send you a notice about that so you can get right to that information. But we also provide you a weekly federal newsletter, and you can set up customized alerting as well to keep you up to date. So I appreciate your time. I'm going to turn the session back to Barry so we can finish his fabulous presentation. And so Barry, let me hand off to you. You should have control and be able to share your screen again.
Okay, so you should now be looking at a slide that's the last slide we were looking at, and now you should be looking at a slide that says heart failure with, which is the next topic we're going to explore.
I'm not seeing that yet, Barry.
Was I supposed to?
You need to share your screen?
Share your screen again?
I didn't see an item that gave me that. Where am I? Okay.
I changed. Let me just try it one more time.
There we go. Show my screen.
Got it?
I know what's going to happen.
There you go.
Yeah, perfect. Thanks, Barry. Oh, we're at the beginning, though.
Close your eyes while we move quickly to slide 40. And,
thanks, Barry.
Yeah. Okay, heart failure with. This is a series of coding clinics that are actually very important. They're among the type I described that are empowering. It goes like this. Coders didn't like the previous coding clinic first quarter 2014. Using the coding clinic advisor process, they wrote in and suggested that coding clinic reevaluate a previous coding clinic that said you can't use the abbreviations HFPEF, heart failure with preserved ejection fraction, and HFREF as preserved with reduced ejection fraction. And the question is phrased again, would it be appropriate to code diastolic or systolic based on those abbreviations? And the answer is, based on information, the coding clinic and the cooperating parties went and got advice from the American College of Cardiology. They have reconsidered the previous coding clinic and have now changed the advice, and this is how it works. The abbreviations, heart failure with preserved ejection fraction, may also be considered systolic function. With preserved systolic function is diastolic heart failure. By comparison, the reduced ejection fraction is in fact now able to be reported as systolic. These abbreviations can be reported as these diagnoses. And here's the answer. Therefore, when provider has documented these abbreviations or other similar terms noted above, the coder may interpret these as diastolic failure or systolic failure respectively. The phrase other similar terms has got people wondering, what if I'm only given the statement of failure, but they tell me I have an ejection fraction of a certain number? Can I then decide that that number equates to a normal ejection fraction and call it one or the other, or a not normal ejection fraction? And I'm falling in the camp where we really shouldn't be interpreting clinical information, although I know other folks have argued vociferously that by definition, an ejection fraction of a certain value tells us whether it is preserved or reduced. And I just want to make you aware, because I know that the phrase other similar terms you'll figure out that you will have some questions about that, but I at least wanted to bring it to your attention. In short, to summarize that coding clinic, to bring out the relevant phrases, pretty much this is the kind of slide you could cut out and hang over your desk to help you get the hang of this until you get the abbreviations down, unless they are just routine to you already in your head. But the PEF is diastolic heart failure, the REF is systolic heart failure, and that's pretty much all there is to it. Next, I want to talk about a big, well, it's a little change, or it's just kind of a clarification. Diabetes-associated conditions. The questioner starts by saying the alphabetic index for diabetes with includes listings for conditions, which this was not how it was structured in ICD-9. Does the provider need to document a relationship between the two conditions, or can the coder now assume a causal relationship? And the answer is, this is one of those empowering coding clinics as well. According to the official guidelines, with means associated with or due to when it appears in a code title. An important reminder. And this is how it is meant to be interpreted when assigning codes for diabetes with manifestations. Important statement here is the classification assumes a cause and effect relationship between diabetes and certain diseases of the kidneys, nerves, and circulatory system. And right off the bat, people start going, well, what about retinopathy? Well, retinopathy is really a circulatory disorder affecting the eyes. That's where I fall on that one. But the last paragraph, assumed cause and effect relationships in 9 are not necessarily the same as in 10, and this is how we want you to do it in 10. However, and if the physician's documentation says the diabetes is not the underlying cause of the condition cannot be coded as a diabetic complication. And you'll recognize the intent of this paragraph because it's like the obstetric coding guideline, where everything obstetric is related to the episode of the pregnancy, unless the physician specifically states it's not, and that's a written guideline you'll find in the guidelines as well. And lastly, if you can't determine, query, the catch-all phrase we find in all our coding clinics, a quick look at the actual guideline, 1A15 for the term with. The term with should be interpreted to mean associated with or due to, and they're now applying this to diabetes and associated complications. The answer goes on, and this is not a particularly helpful slide, that if it really talks about assuming a linkage, and in fact, the linkage is assumed with diabetes now. Couple of coding clinics that help us drive home the point. Patients are type 2 diabetic with a foot infection. We have a quote, diabetic foot ulcer with skin breakdown positive for methicillin-resistant Staph aureus. The patient has also been diagnosed, and you'll notice this is not quotations, but this is where the interpretation comes, polyneuropathy, end-stage renal disease on maintenance hemodialysis. Does ICD-10 assume a cause and effect relationship between the DM, the ulcer, the neuropathy, and the end-stage renal disease, or how do we code this case? And here's the answer, and I've highlighted the real point of the coding clinic, the diabetes-related, diabetes mellitus with foot ulcer, because that statement told us it was a diabetic foot ulcer. You code the additional code, use the additional code for the chronic ulcer, but E11.42, diabetes mellitus with diabetic polyneuropathy, and E1122, diabetes with diabetic chronic kidney disease. The association between the diabetes and those conditions is now assumed based on the term with, and that they occur in the record simultaneously, following the intent of that coding clinic. But as you would expect is the case, there's exceptions to every rule, and we have the coding clinic from fourth quarter 2013 that tells us that ICD-10 assumes a relationship, that a very old coding clinic, 2004, assumed the relationship between diabetes and osteomyelitis and wants to know, is this true for diabetes and osteomyelitis in ICD-10? And this was a real game changer. When we read this several years ago, no, ICD-10 does not presume a linkage between diabetes and osteomyelitis unless the provider documents a specific linkage of the two. Just wanted to keep that in mind. Diabetes, type 2, and ketoacidosis, what is the correct code assignment? And the answer, in fact, is there is no code for that in ICD-10. We should be using E13, other specified diabetes with ketoacidosis without coma. You know this is the wrong code because type 2 diabetes by now you know is E11. Basically, the sentence given perfect limited choices, it was felt it would be clinically important to identify the ketoacidosis, is a means of telling us that they forgot, they left a code out, and the National Center for Health Statistics intends to fix that. And that will be fixed for fiscal year 2018. It is not currently included in the table for 2017. Worth pointing out that the World Health Organization's original version of ICD-10 had a code for type 2 diabetes with ketoacidosis, but the clinical modification people decided that it wasn't going to happen that often, wasn't that common, and therefore code E11.1 was left out of the United States version. A couple of items I wanted to add that are in the index, some changes. In ICD-9 we had the term poorly controlled. Which was instructions there told us that poorly controlled was to be used the fifth digit for not stated as uncontrolled, a double negative meaning code poorly controlled as though the diabetes were controlled. But this has been corrected in ICD-10 using the phrases out of control, poorly controlled, and inadequately controlled, all to be reported as diabetes with hyperglycemia. Type 2 with hypoglycemia. We now have a specific code in ICD-10 for hypoglycemia. You recall in ICD-9 that there was a code, it was a catch-all which included hypoglycemia. It was also the code that included diabetic osteomyelitis, as you recall. Hypoglycemia as a significant condition has been drawn out. And at this point, we need to stop to talk about some questions, but I want to talk about one big item we did not get to, and I recommend you spend a significant amount of time reading this in the coding clinic. I've given you a number of slides on the topic, but really what has happened is, despite however it is we thought we were going to be coding of the repair of obstetric perineal lacerations, coding clinic now gives us a set of new codes. Some are the same, a couple are different, but it's really intended to follow the guideline about coding, using one code to code the deepest layer of the repair. And I recommend you spend a little bit of time with that. And I regret that we didn't get to the remainder. I was overly ambitious with respect to what we would cover today. We only have so much time, and I promise we will do this next time on these topics. And I believe we're going to take some questions now.
Thanks, Barry. Sure. We have a question from Connie, Barry, and it appears as though Connie was audited, and she had an audit where the patient's prior ED encounter was scanned in addition to their HP. And Connie hadn't coded from it, and the auditor took basically, in quotes, a gazillion codes from the ED history that wasn't included in the actual HP, and she ended up getting a really low score on that particular case. And she couldn't figure out how that was okay. The actual auditor said that because it had been scanned with the HP, that it was accessible and part of the HP. Is that correct?
Well, yes and, well, yes. The information from the history and physical if I understand correctly, was included with the remainder of the visit. Coding guidelines, and we can address this written for this individual, tell us that the entire record can be used as sources as long as we are certain that those conditions are current and relevant, as we talked about in the coding clinic during the presentation. That's a very important part, and it's always difficult to answer a question like this without actually having the record in front of us to debate some of the fine points of the actual documentation. But in general, referring to the history and physical and using the entire record where we understand those diagnoses to be current issues for the patient would be reportable.
Great caveat, Barry. The next question is from Sharon, and she asks, when a patient is admitted with acute blood loss anemia from a gastric ulcer that is no longer bleeding on admission, how should that gastric ulcer be coded?
That's a tough question that we could spend much time debating. Perhaps one way to look at it is that the ulcer is not bleeding at the time the patient comes in, and therefore you have an ulcer that is not bleeding, and that's the fact is a fact. But the fact is that the patient, what's the patient being treated for? Are they there for the blood loss anemia, or to keep an eye on the patient to make sure the ulcer does not start to bleed again? And that's really, I think, the crux of the matter. Are we treating a bleeding ulcer even though it's not bleeding at this moment and may continue to bleed or start up again? Observation for that service may be appropriate. That's a tough question.
No, absolutely. Thanks, Barry. One last question. According to the guidelines for sepsis, is this always listed first even though it may not be the reason for admission?
Interesting question. I guess my question to the questioner would be, what were the other options? What else was the patient being admitted for treatment of? With respect to the sepsis, sepsis would be sequenced first rather than the underlying localized infection that may have caused the sepsis. But I'm not sure that's what the question is getting at. It may be a broader circumstance. That's a tough one as well without the actual documentation.
Absolutely. Well, Barry, we are at the bottom of the half hour. I want to thank everyone for attending the fantastic webinar by Barry Libman for ICD-10 Coding Clinic Update. We want to thank you all. We are doing a subsequent session. Feel free to register. It is scheduled for next week, and we want to thank everyone for attending. Don't forget, after today's webinar, about 48 hours, give us about 2 days, the updated handouts will be sent out to all registered for today's event as well as your CEUs. So don't forget to fill out the survey. We want to be able to best serve you as our customers, and we want to wish everyone a pleasant day. Thank you.